08. As a quorum of the committee is in attendance, I would like to call to order the meeting of the Central Health Strategic Planning Committee. As a reminder, some of our committee members may be also participating by video conference, so the staff will be managing video and audio feeds of all participants closely to make sure we have a legally compliant meeting at all times. The first item of business is public communication. Members of the public who wish to make comments virtually during the public communication portion of the meeting must have registered with Central Health via the online form or by telephone no later than 10:30 a.m. today. Yersinia, did anyone register to make comments?
No, Madam Chair, nobody registered to make comments today.
Thank you, Yersinia. We will now proceed to the committee agenda. Number 1, review and approve the minutes of the March 9th and March 11th, 2022 meetings of the Strategic Planning Committee. Do I have a motion?
I move that the committee approve the minutes of the March 9th and March 11th, 2022 meetings of the Strategic Planning Committee.
Do I have a second? Thank you. Yes.
Speaker.
Manager Musaitov seconded.
I have a question.
Yes, sir.
I think you said March, this is May.
Oh, I'm
This
so
is
sorry.
March 9th
It
and
says
May.
March 9th. I'm reading exactly, literally.
Yes.
So they made a mistake. It's May 9th, I'm assuming.
Yes.
No, March 9th is.
March
Okay.
9th and May.
So-
Oh, I'm
Nothing
sorry.
in
Let me
April.
restate that. Okay. Review and approve the minutes of the March 9th and the May 11th, 2022 meetings of the Strategic Planning Committee.
That is exactly what I said.
Oh, great.
I
Okay,
made
thank
that
you.
motion.
Yes, thank you so much. Thank you, Manager Valadez. And
I'm just curious, is there a technical issue that happened during March that our vote was not accepted? Or
Have a meeting.
had a meeting? Okay, sorry. Thank you.
It was a good
Yes.
thought.
thank you. And so Manager Valadez motioned and Manager Musaitov seconded that motion. And number 2, receive and discuss. Oh, can we vote, please? Yes, would everyone vote?
Aye.
Aye.
All those in favor say aye.
All those in favor say aye. Okay. Any naysayers? No. Okay.
I like that.
Thank you. So number 2, receive and discuss an update on the next phase of Central Health's ongoing equity-based systems planning work, which includes developing operational implementation and financial sustainability plans in support of the board-adopted Healthcare Equity Plan, aka Equity Focused Service Delivery Strategic Plan. And Monica Crowley will be presenting.
Thank you, Monica Crowley, Central Health. This is a quick verbal update. We are going to be coming back to you next week and then next month with more details on our next phase of the operational implementation and financial sustainability planning work that is in support of building out the healthcare equity plan that you passed as a board in February of this year. The first update is that we are still in the RFP process on selecting a consulting vendor to support the financial modeling and the sequencing and staging work to build out the healthcare equity plan. We expect that RFP process to be completed within the next couple of weeks. So we'll be able to come back to you with a deeper update on this work that we would like to really begin in earnest in August, that will continue into the fiscal year 2023 budget year. And we should be able to come back in July for the deeper dive and to request contracting authority with a proposed consultant. The second part of this brief update is to let you all know that we had applied for a grant from the Episcopal Health Foundation to support this second phase of the equity-based systems planning work. And we learned in the past couple of weeks that we were awarded $600,000 to support our work with the consultants on the financial modeling and on the sequencing plan. And we'll be coming back to you next week with a proposal for a request for you to accept that $600,000 award.
Excellent.
Any comments? Yes?
Thank you, Monica. Is this an additional 600,000?
Yes.
Yes, ma'am.
Okay.
Yeah.
Do you know if that's gonna happen for every phase?
Do you know whether or not we're going to be asking for the Episcopal Foundation to support us as we go through each phase? And if so, how many phases are we talking about?
Yeah, we had talked about, this was in the overall scheme of
Right.
the work that we started in 2020.
Yes.
We're in phase 4. And in the proposals with the Episcopal Health Foundation, it was just the last 2 phases. So they funded what was our phase 3, which was the strategic planning, service delivery strategic planning efforts that led to the healthcare equity plan. And then this is the kind of final phase of the service delivery planning effort, which includes the financial modeling of how do we build out this 7 to 10 year plan, and then the operational implementation, long-term planning of kind of what's the most appropriate best practice sequence of developing different parts of the system, working with our partners over that same time frame.
So just
So
for-
these are the last two
okay,
phases.
for clarification purposes, we're talking about implementing all the operational component of the equity plan and not necessarily the financial yet. Is
No,
that
it's
correct?
both.
Okay, so
This-
it's both operational and financial implementation.
Yes.
Yeah.
Yeah.
Development and implementation. Okay.
So
thank you.
yeah, how are we going to do it, and how are we going to pay for it?
Yes, Manager Musartov.
Well, thank you, Monica. Can you hear me? Not sure. Well, thank you, and I appreciate that. I just also want to thank Episcopal Health Foundation for their commitment to health equity and to the work that we're doing here in Central Texas. And I really appreciate all their efforts. Thanks.
If no further comments, thank you very much. No motion is necessary. And item number 3, receive and discuss updates on the proposed fiscal year 2023 strategic priorities, including multi-specialty clinic services at the Rosewood-Zaragosa Health Center, direct clinical practice infrastructure, and Central Health's implementation of the Epic electronic health record software. Mr. Giesland, Mike Giesland, Jonathan Morgan, and Dr. Alan Shalsha will be presenting.
Thank you. So members, I'll provide a brief overview and a preview of what else is to come that's related to this presentation right here. But as you can see, we're talking about the direct provision of care, which is part of the board approved health equity and service delivery plan from February. It has an outward facing component to it, because if you think about providers interacting with patients and improving health and overcoming health disparities, but behind all of that, we are also working on business cases as part of our budget development process to build up what our support operations look like. And you'll hear a lot about clinical support, but that is different, separate from the operational support that you need to be a great organization. And just to sum it up, as we're working on the direct provision of care and all the necessary clinical supports, sitting behind that is a significant amount of operational and organizational support. And that means staffing up, building out more sophisticated processes, and making sure that we have the necessary on-demand capacities to add the people when we need to, bring on board clinicians when we need to onboard them, making sure that we can equip them with technologies, making sure that departments are properly supported so that, we can do what we need to do. So understand that there's a lot that sits behind this. You'll get the opportunity to have full line of sight into it, as will the public, as part of our budget development process, but wanted to preview that. Thank you.
Thank you, Mr. Kiesling.
Can you all hear us okay? Excellent.
Yes.
Good afternoon. Thank you for having us. And Dr. Shalsha and I are excited to be here and share some updates on this work. As Mike mentioned, this is leading up to the FY23 budget, the proposed strategic priorities for that budget, and the budget resolution that would accompany that. Would you go ahead to the next slide, please? So we've grouped 3 separate topics into this presentation with the idea that any one of these are significant enough to have their own presentation and deep dive discussion, but it's difficult to talk about one without referencing the others. They're very interrelated. They're very dependent on each other. So we thought we'd try to tackle all 3 of these topics today. And then of course, we're happy to come back throughout the board's deliberations on the budget and the priorities as you get further along in your processes. So Dr. Shalsha is going to lead us through some discussion around the multi-specialty clinic and the services in that particular initiative. And then I'll pick up with a discussion around our clinical services infrastructure and our EHR implementation. I should note that this is a rapidly evolving and developing set of topics, and that's why you didn't get a read ahead until yesterday, because as recently as Friday, we're meeting at Rosewood-Zaragosa with clinical subject matter experts and continuing to refine and develop the scope of services. So if we would have provided you a presentation last week, it would already have been out of date. So we're really trying to get you the absolute most recent information that we have available. I'll turn it over to Alan.
All right. Thanks, John. Good afternoon, Board of Managers. The information that we are going to present fits within the health equity plan and its strategic imperatives. It will increase the information that we share, will increase access and capacity, improve care coordination, increase member engagement and enrollment, and improve systems of care. Next slide, please. Much of the information that we'll be sharing will focus on FY24, but we did want to assure the Board of Managers that there's a lot of current work going on with FY22, and the information we share will affect FY23 and FY24, but there's a lot of work that's been engaged in now, and we look forward to coming back to you all and presenting that information and sharing a little bit about our transitions of care and case management and other initiatives. So that is still currently active. Next slide, please. As you all are aware, when we were presented with the gaps in care, there are significant opportunities that exist across the care continuum. If there is a moderate care gap, that means that we're meeting about 70% of the community need. If there's a significant care gap, that means that we are meeting less than 50% of the community need. The Board of Managers has worked on increasing access to specialty care for years, and by us focusing on that multi-specialty clinic, we have taken steps forward in the past, and we look to take leaps forward in the near future in an effort to meet the need. Next slide, please. When we did present on the multi-specialty clinic to you initially, we touched on 5 specialties being present. If you look at the current list, there are 6 listed there. In our conversations with community care, it was presented that they would entertain transitioning the pulmonary care that occurs within CUC to potentially this multi-specialty clinic. So that has been one of the changes. Obviously, we are considering the utilization of Rosewood-Zaragosa. RZ has such rich history of care of different types within our communities. And so it really fits well utilizing that clinic moving forward. If we look at the FTE allocations, so FTE stands for full-time equivalent, we're basically talking about the providers or the people that would be staffing this clinic. If you all look down at that FTE allocation, you may see that there's a 0.6 allocation, a 0.3 allocation. I'll use GI as an example. The reason that there is a 0.3 is we are also speaking to community care and considering the partial allocation of specialty presence that they have within their clinics. So 0.3 allocation is a day and a half of GI care that currently exists within CUC. And when we move to RZ, we are actively talking with our partners to do what is in the best interest of our patients. And if it makes more sense, creating uniformity and expanding the care, but expanding the care and locating it in a center of excellence as related to specialty, then that is what we will do. So that's why you've got that point allocation there. When looking at the breakout of our specialty care clinic, we're looking at the ratio of 2 medical assistants to every provider. We did want to ask for forgiveness ahead of time when looking at the provider FTE, because as we start working out these clinical programs, we may need an extra physician or an extra physician assistant and 1 less physician, depending on what the care programs actually call for. And I'll give a specific example. We're not looking just to hire specialists. We're looking to create program. So whether it is a heart failure program that exists within cardiology, we may need different personnel to work that program. And as we meet with our subject matter experts and as we build up those programs, we will get more specific information. We'll bring that information back to the board of managers, but it may look somewhat different. I also wanted to point out podiatry. Podiatry has a very beefy contingency as related to staff members that would be working that specialty. Podiatry will serve kind of an ambulatory care need. There will also be a wound care access portion of that. Casting will be available, nail care. And so the contingency for podiatry is pretty rich. As we work our way down the list, there is a section for collaborative care team members, and this is our dietitians, our pharmacists, our social workers, our case managers. I think one of the aspects that we are really looking forward to is removing any barrier that our patient has that is not necessarily directly linked to their patient care. And so getting those collaborative care team members into that care team right from the very start is important to our patients. You see in the yellow and in the green that we have FTEs allocated for both transitions of care and for respite. Transitions of care, Dr. Hamali Patel is on board. She's our director of transitions of care. She was previously employed by Dell and by Ascension. And as she starts to scope out the most critical need, it may be that we need to set up our own governance of care within skilled nursing facilities or put transitions of care personnel within hospital environments. And so we have created the availability for her to build teams, and that'll be in the next fiscal year. As related to respite, right now, we are case managing people in a warm, dry, safe environment, and that is what we are referring to respite. And there are various aspects to respite as far as simplicity, a more simple aspect, and then becoming more complex related to care. What our legal folks are looking to is what is the next feasible step we can take, and can we actually start doing med reconciliation and wound changes and physicals and governing more of active patient care in the respite environment. And so there are some FTEs allocated to that need. All right, next slide, please. We wanted to show the impact that this clinic could have. So if you would please take a look at the clinical encounters that are presented here, those clinical encounters are worked out looking at between 15 and 17 encounters per day. Many of these patients are complicated patients, or they would have procedures associated with their visit. And so we're not going to be seeing 30 patients a day. The encounters were calculated on the number of work days. So if you think about, let's say, 218 clinical days, looking at between 16 and 18 encounters per day, and that's how you get your clinical encounters. Not included in these encounters are e-consults, diagnostic reads, or telehealth. So those would, when we're going to work up RZ, we're actually going to create spaces to conduct those care environments that are separate from our exam room. So those would be additive to these environments. By having a multi-specialty clinic, we really create efficiencies and good patient care. And so our diagnostics, and we'll spend quite a bit of time in just a bit talking about diagnostics and sharing with you all what diagnostics are we're planning to put in place. But the throughput for our patients should be cleaner, smoother, quicker, more efficient, because they're seeing our providers. And then we will, at this point, still be contracting for our ambulatory surgery centers, but the providers will, the patients will be in our environments, and so we can handhold them into those environments, and so and drop less care that way. As far as enhancing the patient's experience, right from the very start, we're looking at expanded hours. So that means earlier in the morning, later at the night for some days. We are looking at weekends, whether that means that exams would be conducted on weekends or procedures or diagnostics would be conducted on weekends. So those are conversations we're having now. We touched on e-consults, telehealth. Our goal is to remove any barrier to care that exists. And so utilizing the electronic health record, and John will talk quite a bit about Epic, but utilizing the electronic health record to gain access for our patients. So either they book their appointments that work for them, or that they can conduct remote visits as is appropriate for their care. Next slide, please. We wanted to share an example of the creative scheduling that is going to be engaged when we eventually get to RZ. Now, included in this scheduling paradigm, and this is just a sample, this is not exactly as it's going to exist. Pulmonary is not included here yet, right? And this is a Monday through Friday schedule. And so weekends, diagnostics, e-consults, other things are not included here. So we've got some significant work to do. We've shared with the Board of Managers that we are starting from scratch. So we are building the structural environment, we're building the clinical environment, the electronic health record system, the policies and procedures, what we expect from our teams, the training and the competencies to make sure that people learn that. And so right from the very start, there are a lot of to-dos in order for us to stand this up and do it properly. Next slide, please.
So there's quite a bit that goes into this, that it may seem physical on all tangible, but there's a lot of things around the patient experience that also have to be brought online in order for this to be a good experience for the patient. Thank you, sir.
All right, thank you. To John's earlier point, what sits in front of you is a floor plan. Please don't look too closely at this. We made it really small on purpose because this is what existed on Thursday. And then we got together and the architects and members of Stephanie's team shared with us that we're basically tearing down greater than 2/3 of what lives in RZ. And so what we were trying to do is to save what we could and then construct a functional care environment around that. And what the architect told us is that, number one, the walls don't make it all the way up to the ceiling anyway. And so we're not HIPAA compliant because noise travels over those walls, and that there wouldn't be a lot of additional expenditure to take everything out and build it according to what best works for the patients. And so the best laid plans that existed on Thursday, to John's point, had changed on Friday when we met with our neurology subject matter experts and our GI subject matter experts and walked through the clinic and decided to start anew. What we did want to share with you all is some of the diagnostics that would sit in clinic. Now, there will be some diagnostics that don't need active floor space, such as Holter monitors for cardiac needs. There are now sleep studies that individuals can take home. And so those may be stored within the clinic, but don't necessarily need floor space. What sits on the upper left corner is a PFT, pulmonary function test. And so this allows us in clinic to test the lung capacity of our patients. If you move one step down, that is a weight-bearing x-ray. For podiatry, there are weight-bearing access points within town. But what happens is when we send patients to a contracted x-ray environment, the majority of the time, the patient gets a non-weight bearing exam because the technicians don't actually want to make somebody who's got a sore foot stand on their sore foot. And what that does is it brings back an image that is not as useful for the podiatrists. And since over 60% of our patients or so will need weight bearing x-rays, and this does not take up a lot of room, we're looking to put some weight bearing x-rays in place. Podiatrists also need to look at the integrity of the vasculature and of the blood flow as it gets to the foot. And so this is basically a type of an ultrasound, an ABI. They need to do ABIs and TBIs. Now this machine may exist within our RZ environment, or we may contract out because there still needs to be a radiology read for this. So this is one that we are considering the pluses and minuses. Sitting next to that is actually the podiatric chair that looks different from some of the exam chairs. It does recline all the way, and so it can be used for general purposes, but there is more ambulatory action on that foot piece so that, whether it's wound debridement, whether it's putting a cast on, whether it's, trimming some of the nails, or just general exam, it's a much more functional environment. Next to that is an echo, so basically ultrasound for the heart. That'll be utilized in two environments. We will have an echo room that sits unto itself, and then we will also utilize echo that sits next to a treadmill so that we can actually stress test our patients using echo. And so there will be two different environments for that. Next to that sits the EKG, and the EKG modality is now, the machine is very small, right? So those can be utilized within the exam room. They integrate smoothly within the electronic health record system. And so we will have a few of those, and then you see a treadmill as it exists, or as we will set it up, within the exam rooms. So this is an example of what we're planning in addition to lab, CLIA, vaccines, meds, and we will share more information as those programs are then built. Sir.
So just a couple of things that I would emphasize that we've certainly talked about before, but the things that we should recognize here are the dedicated capacity that is focused on our patients first. That is going to just be a remarkable change in the system, as Alan said, a very, very big step forward for our patients in addressing their needs. The on-site diagnostics, I don't think we can really overemphasize. Very few of these are available in the clinic environment where our patients are going for these specialties. Some of them are, but some of the more advanced diagnostics, having those on site really reduce barriers for our patients, make treating patients easier on our providers and care teams. And I think we will expect to see better outcomes as a result. Operationally, opportunities to just approach this clinic differently, to right size the e-consult components, the referral management aspects, the transportation assistance, how we register and bring our patients into the environment, and just as importantly, how we connect them back with primary care. There's a lot of opportunity in a model like this for us to really advance the overall care model and operational model. And Dr. Brenson, if it's okay with you, we'd really like this to be more of a discussion than just a presentation. So before we jump into infrastructure and the EHR, if there are any questions, we're happy to pause here for a few minutes, if that's okay.
Thank you so much, Mr.
Yes,
Munger.
ma'am.
Any questions? Yes, yes, Manager Musaita.
Thank you for the presentations and work you do. Now, you just highlighted, first of all, Jonathan, about connecting to primary care physician. Now, the biggest issue across FQHCs in general is how do we connect primary care physicians with specialists and who owns the care, and especially with the population that we're serving who are underserved, complex patients who may have more than one chronic illnesses. So just wanted to know what is your take in terms of that communication piece and managing that care of the patient in general. So that's really a critical piece, not just accessing the specialist, but how do you go back to the primary care physician and who to manage that care. And another thing, you talked about Dr. Alan.
Or Alan.
Sorry,
All
Dr.
good.
Shelta, about creating programs, not just services. And I think you may have heard of Project Echo, where it's more of a tele-mentoring project that really provides, because you cannot generally bring in all the specialists in the world. You cannot. And there are some things that a primary care physician can do that is typically done in the specialist's office. So I would encourage you to look into this project and how we can enhance the care for our patient by this tele-mentoring project that I think it's an evidence-based project, and there's a lot of work, and it's across all different specialty, not just one area, and especially cancer as well, where I did not see a service that I don't know how our patients are receiving oncology care. So thank you. That's a lot
Can
to
I take
absorb.
first shot at
Please,
the
sir.
title?
Please.
So thank you for asking those questions. I think one of the advantages that we have, and I spoke to Mike Pignoni of the med school a few weeks ago, and he said, Alan, just tell me what electronic health record will you all be utilizing? And I said Epic. And the reason he asked the question is exactly the reason that I think you had asked the question is we're using the same system that CUC is using. And right now, Peoples is undergoing an evaluation of what system they want to be using in the future. And there are systems like Ocean, which is an aspect of Epic. And if that is something that they then choose, we will have a really good portion of our under-resourced patients that are all utilizing the same system with having an opportunity for an exchange of information. So that's one aspect of that. As we also build out the transitions of care teams, one of the most important points of our transitional care teams is to make sure that the information that sits in one clinical environment gets to the next clinical environment, and that we don't live in isolation, or that providers don't live in isolation when treating patients. So to your point, we're going to do our best to make sure that we do have those linkages. I did my training in New Mexico, where ECHO was born. We also used kind of the ECHO schematic at CUC, where we set up SMEs for rheumatology and for cardiology. And that is some of the work that we have continued and we will continue here, because to your point, we can't hire, we won't get enough access to specialists, and e-consults in many ways serves as kind of a methodology to get to educate up primary care providers, because what e-consults do is they serve as an avenue for primary care providers to ask questions to specialists. Specialists answer those questions, and the back and forth, and there is access to back and forth. And so what has been shown is that when primary care providers have that ease of access, they very seldomly ask the same question twice. And so their practice skill levels actually start to increase. And so that active exchange between our specialty providers and our primary care providers will also up the ante for primary care. Anything you want to add?
Just a couple of additional points on both of your questions. I mean, Epic is certainly a big part of the strategy around connecting with primary care. Being on the same system as community care is critical. That investment that this board supported several years back for community care was intended for us to be able to create a central health component of that EHR so that we can connect. All that data is in the same system. It's one instance. I'll get into a little more detail on that, but where there's a shared patient between community care and central health, that data is already in the system and available. So in addition to Epic, again, we have the ability to program services differently, like e-consults or Project Echo, where we are able to dedicate time towards that activity that's incredibly difficult to do in a private practice, fee-for-service type of environment, where we are a small portion of the payer mix for some of these larger practices, or our patients are. So creating a unique workflow around 10% of your patients becomes a pretty big operational challenge. So I think that's the other part I would add to your first question. Secondarily, I think of the specialties you see here, there are some that we plan to hire directly, and there are others that we plan to partner with others, particularly the medical school, to hopefully be able to recruit providers into the community that aren't here today in some of these specialties.
Just one last thing, in terms of the interoperability of data, our patients who are receiving any surgeries in like hospital admissions, do we have access to inpatient data from hospitals for our patients?
No,
No,
go ahead.
That's
this is
really-
a harder answer. You answer that one.
It's a yes or no at this moment.
I think the first thing I would say is the data, the hospital data that is available to primary care now has improved pretty significantly with the addition of Epic. It's connected with regional and national HIEs that both Seton and St. David's here locally contribute data to. And so that data is available in the system. I think almost to the point of it being overwhelming. There's so much data, and it really becomes more about making sense of that data. So data has improved. It is still far, far, far from where we want it to be. So again, as you know, we hope to build out a system and not just this individual initiative. The more providers and facilities that are on this EHR, the better that information flow is going to get. But where providers are not on this EHR, again, we have the ability to appropriately resource that function to make sure that records are changing hands, that treatment plans are being transitioned from whether it's back to primary care or whether it's into a post-acute environment or home health, or from specialty to specialty. That's a large part of what we need to think about, and part of what we'll talk about from an infrastructure perspective.
Sorry, there are two more things that I'd like to add to that. And from now on, any difficult questions, please direct them to John, and then I'll take all the easy ones. I think this is phase one, right? And so as we look at Hancock and we look at either expanding some of these care environments or adding new care environments, infusions, cancer care, like what is missing and what do our patients need access to? We got to walk before we run. And so we're starting here, but this is not going to meet the need. And I think we all understand that. The other thing is that I met with our director of transitions of care yesterday, and she's starting to prioritize areas that we should be concentrating on. And one of the items that we talked about is when we put care teams in the hospital, which patients are more critical and how is she going to strategically approach that? And one of the items we talked about is which patients should have warm handoffs, right? And so which patients from the provider teams inside St. David's or Ascension, the provider should actually be picking up a phone and speaking to another provider when a patient is being discharged. And this is work that Hamali has great relationships with our Ascension partners, and we're working, on building bridges with St. David's so that we develop exactly the same thing. But this is in their best interest to start developing those processes, because the better we take care of our patients, the better it is for patient care, but the less likely they're going to be readmitted. And so those are some of the conversations that are being undertaken now. Sure.
Dr.
Thank you very much. That was very informative and very helpful. And very comprehensive in terms of what your strategy. It focused primarily on the in-house service delivery system. What are we doing? And maybe you're going to talk about it a little later in the transportation, but we have one site for population that is dispersed throughout the county, many of which are in the Eastern Crescent, which we're most familiar with, but they're in other parts as well. We've identified this site primarily because of cost and history and connectivity. I understand that. But my question is, how do we bridge the gap to ensure those people who live out in the hinterland, so to speak, from this location to be able to get access to these when they need it on frequency without transportation systems connected? Can you speak a little bit about that?
I'll try first. So it's another great question. I think one of the things that we do consider with specialty care is the majority of patients who need to go to the specialist or not, they don't need to go to the specialist on a weekly basis. Now, for some patients, like somebody with a diagnosis of heart failure that is, not controlled, they may need more frequent visits, but that is where we need to consider either telehealth and or transportation. So transportation is a real, and John will talk about an infrastructure build, and that infrastructure build that we will be focusing on is all of the things that people don't see, but the barriers that exist, to your point, for patients who may be working atypical hours and not have transportation. And so those are considerations that we understand exist and are out there, and they're on the to-do list to, do we need a van service? Do we need after hours telehealth? All of those things I think are on the table to be considered.
I would add just a few things if that's okay, or maybe emphasize a few. To me, there are 4 primary barriers that we're trying to address with this model from the beginning. One is quite simply just creating more timely access. It becomes very difficult for our patients if they're having to wait 4 or 6 months to get into the specialist. So that by itself, I think, will be an improvement regardless of where the clinic would be located geographically. Having that timely access from the time the specialty need is identified to when it can be made available is a big part. Alan mentioned e-consults and telemedicine, so that we're not always bringing the patient to us, but we're trying to bring the specialty expertise to where they are, or to their primary care clinic that may be a lot easier to navigate to in their community. Transportation and pharmacy copays are the two largest or most frequently cited barriers to care that we hear across the board. So as part of the infrastructure development, we'll speak to transportation as a part of that. I mean, we provide some transportation assistance today to our patients to access medical services or pharmacy services or eligibility. That will be a key component of what we're building from a system infrastructure perspective that isn't specific to Rosewood-Zaragosa, but would also serve additional clinic locations as that comes online. Pharmacy is a barrier that we don't have a proposal for today, but looking at pharmacy copays, particularly for patients with multiple chronic conditions that need multiple prescriptions on a monthly basis, that can be cost prohibitive and can be a barrier to our patients being able to manage their own health. So we're definitely taking some steps. It's certainly not the most geographically convenient location for all of our patients, but it's also our first site. So I think we'll be able to make some improvements as we go.
Okay, thanks very much. That's very helpful. I think for a board, one of the things we need to talk about is, are we providing the adequate resources necessary to address our population? And the points that you're making speak somewhat to this. You have to compromise with the resources that are available. So as a board, we need to start talking and recognize is that, as the 11th largest city in the nation, serving a county of almost 2 million people, are we providing for our population at risk? And I say that because I understand the importance of one clinic, but in reality, I would think that we'd look at maybe a second one, or have in the planning phase, a second one, to be online so that we as a board can begin to start addressing those issues. So I just want that on the record so that as we start looking down the road towards planning, that we incorporate those kinds of concerns you raised in our deliberation or the budget.
Absolutely, I couldn't agree more, Manager Jones. I'll just point back to the prior agenda item, the continued strategic planning effort, that operational and financial sustainability plan should help answer some of those questions and help point to not just these 4 immediate clinical practice areas, but the ones that would come beyond that.
Thank you.
We're really focused on the 12 to 24 months at this point, and I completely agree with your point.
Thank you. And Mr. Geisler.
John, if I may, yes, in response to Manager Jones. As Alan said, these are programs that we're establishing, and it's when we think about future locations, right now we're trying to establish very quickly a strong and impactful presence in the specialty care arena, but it remains to be seen, even beyond that 24-month period, where the different services will need to be located. And if you're thinking about programs, and I really should let Alan expound on this at the appropriate time, it may make sense to have a particular program, for example, in Colony Park, or it may make sense to have it at Hancock or at Rosewood-Zaragosa, or fill in the blank, some other location to be determined. And so there's a lot that's going to happen in what is going to, this 24-month period, to go by very quickly. Second, I think, when you talk about providing the resources, you will get when we start talking about the budget for this upcoming fiscal year, that's going to be the point at which you'll see this is what it's going to take to invest in the lives of our patients to be able to provide the resources necessary. And so there'll be a lot of robust discussions around making those investments and having the necessary supports for our patients.
Just one last comment to what CEO said. I agree, and I think that as board members and as a board, we need to be on record and be proactive in letting the public know that these are the kinds of things that we need to take on as our responsibility, and not just sort of reluctantly going forth. I think we need to be more proactive in those ways, just as Cap Metro is being proactive, just as APD is being proactive, just as other agencies of government are being proactive.
Yes, sir. We'll continue on our trajectory of being proactive as we are today.
Would like us to move to infrastructure?
Yes, please.
Next slide. Yeah.
Oh, wait,
I'm
more
sorry.
questions. Sorry. Yes, Manager Zamora.
Thank you, Dr. Chair. And John, you've heard me say this before when you and I and Mark Hernandez would meet at those lunch meetings we would have. Expansion of primary care. I mean, Alan and I were trained to do all this stuff. As family physicians, we were trained to take care of these patients. Yeah, we would need some help, just like you're discussing, with some of the more integral stuff in the specialty. Most primary care doctors can handle everything you're discussing. So you and I discussed this years ago about expansion of services to the primary care physicians in private practice to allow them to see our patients. And it's the right thing to do. Because that's one of the things I hear in my practice, because you've heard me say this before, my patients are your patients and your patients are my patients. We share them. I hear it takes months to get in. So if we could expand the physicians by using our primary care physicians in private practice, it'd be wonderful. I think it'd be a godsend for these patients.
You okay if I respond?
Thank you. Yes.
Thank you so much. Thanks, Dr. Zamora. To your point, we have to continue to build those programs. And again, an example of a program that is being built and is very functional because of primary care physicians is the heart failure program. Because now heart failure patients that have an EF of greater than 45 are being discharged within 7 days and going to primary care with an infrastructure built in primary care so that specialty care can see, an ejection fraction that is lower than that and really concentrate on the more critical patients. And so as we continue to move and build those programs and educate up our primary care providers, I think we will reach more of the patient population, take better care of them. So 100% agree.
And
I'm referring to using the private physicians that are willing to see our patients.
so
I'll
point
raise
is
my hand, I'll be the first.
absolutely valid, Dr. Zamora. And, I want to be clear that what we're not doing is pivoting away from development and primary care. We have, fortunately, in our community compared to many others, we have some very strong partners in primary care. Of course, at community care, where the majority of our patients are receiving primary care, also at Lone Star Circle of Care and a People's Community Clinic. You all are aware we've added others to that mix over the years, and will continue to do so, both on the primary care and specialty side. So the second point, and I'm glad you brought that up, Dr. Zamora, is this doesn't mean that we're going to stop working with private practice specialists. And even while we've been developing this, we have contracted just this year with an additional cardiology group, an additional GI group. We're working on a dermatology group. We've also contracted with nephrology in support of the dialysis initiative this year. So this is not a pivot away from working with our partners and other private practices in the community. This is an additional tool in our toolkit so that we can build some dedicated baseline capacity and not have an exclusive strategy to contract. So
Sure.
Thank you for the point.
I understand, but again, we have so many private physicians that are willing to help.
Yes, sir.
Let's get them involved there too.
Understood.
Thank you. Any further questions? Yes, oh,
Just a
sorry.
few comments. So I've already given you, I think, a list of questions that we will have another discussion.
Okay.
Microphone, please.
Thank you. But I also am 1,000% in agreement with Dr. Samora and with Manager Jones. These are not the first times these issues have been raised. And I know at least by me 1,000,000 times for you all who have sat in on meetings with me, at least you, Jonathan, and Monica know this, and poor Dr. Samora. How many times every one of these questions plus 1,000,000 more have been raised by me and concerns. And I'm going to tell you that I'm very happy that this is one of the first times that I have witnessed this board be serious about engaging in that systems change. Okay, and it's more than a systems change, it's an attitude and mentality change. And yes, we are now taking responsibility for our population, and we're not going to be relying on whatever they have access to, or whatever barriers they have to overcome in order to get to that care. So I just want to make sure that we're looking at how we're going to tie them. As I want to reemphasize this, if we're talking about doing this at RC, which I said and fought against the closure, as you all recall, opening it back up and tying it to whatever is going to be developed in the Eastern Crescent. And yes, it's good that we're going to have the Hancock Center built up, because I understood that was going to be our one-stop shop for specialty care. So I'd like to know what the link is going to be between those two, because they're not too far apart from each other. And we're still missing everything on the outer reaches of Travis County. And the only reason somebody in some presentation talked about how things were centered, towards closer to 35. And the only reason that our population is residing in those existing subsidized apartments along 35 is because that's the only place the city and the county built them. They didn't build them anywhere else. So it's not, doesn't take rocket science to figure that one out. But this county has acknowledged that there is a need to move outside the toll road, outside 183. And so how are we going to move to that population and make sure that they can get to and access the care that they're going to need? And not only the care, but the resources, because it's not just about whether you have the copays or whether or not there's a smooth transition from a ER to hospital care, inpatient hospital care, to outpatient, to home. That home situation is the big problem. okay? Because so many of our patients are alone.
Thank you, Manager Valdez.
So
I think that we should move on with
No
the great
problem.
ideas.
I just
and-
want to
yeah.
thank y'all for that.
We'll talk, if we go to the next slide, so up to this point, we've really focused on specifically the Rosewood-Zaragosa proposal and that multi-specialty clinic. These next few slides, and I think there are only 4 left, so we're closing in on the presentation part here. But these next few slides, I would ask you to think about this more as infrastructure from a central health direct practice perspective overall, so not specific to Rosewood-Zaragosa or specialty at any particular location. And that's why we talk about this as part of the discussion, because you really can't do one without the other. But the services and the capabilities that we are growing and developing on this slide will support not just Rosewood-Zaragosa, but also the Hancock Clinic, also the care transitions, the medical respite, and anything else that's down the road for us in that slightly longer term plan, meaning, outside of 2 years, I guess. So just very quickly to speak to some of these, about half of these are existing capabilities that we need to grow or expand in scope. And the other half are things that we need to build from the ground up. We're fortunate to be able to work very closely with community care and leverage things that already exist in that environment. You all know we have fairly robust eligibility services, including a call center that started just a few years ago. So we'll be able to build on that technology infrastructure and that physical infrastructure that we've already put in place. And things like revenue cycle management. You all know better than I do. We have an incredible finance team that has a lot of the skill sets and capabilities, but we've never had a revenue cycle type of need for the central health direct practice. So there are things that we're going to have to scale up and build as we put this work into place. This also speaks to some of the prior questions around patient experience, care transitions, referral management. This is how we resource effectively those activities that are so necessary for facilitating patient care. You go to the next slide, please. So this puts actual position types to the different functional areas that we discussed on the prior slide and really throughout our discussion today. I should note that there are some positions that we are starting on now, and there are positions that are functions, I should say, that we've identified that we'll have a need for, but not in FY23. So at this point, we've really just got a placeholder there. The Rosewood-Zaragosa services we're hoping to have online towards the end of FY23 or the very beginning of FY24. So we're planning as quickly as we can. And you'll see that these positions, as well as the positions on Rosewood-Zaragosa as well, are phased over the course of FY23, so that we can bring in key positions, leadership that can help onboard, train, develop competencies and processes and procedures for the staff that are going to be there, either on site or in these centrally located support services and infrastructure. Next slide, please. And then we have just got 2 quick slides here on our electronic health record. And again, this could be a presentation on its own. The Central Health Board provided some substantial support in the deployment of Epic within the community care environment several years ago. Community care has been working to fine tune their deployment and really optimize use of the system. And that's allowing us to now start to include a central health deployment of Epic. And we've talked about some of the importance of us being on that same medical record system, both from a patient care standpoint and also just a financial efficiency of doing one EHR implementation for both entities. Again, we've already got some important steps in place. We've hired our first 2 Epic analysts. Those are the people that actually build out the environment, the system for Central Health's practice. We're also interviewing trainers who will help train all of those clinical personnel from the first part of the presentation so that we're using that system efficiently from day one. We've got several phases of this deployment. The earliest is actually at the end of this fiscal year in September or October, where we'll have a lighter rollout that is specific to our case management team so that they start documenting in the system first while we build up that larger implementation for RZ about 12 months later. And then you can see a third phase on here in support of medical respite a little bit out beyond FY23. So I think I just spoke to the next slide as well. So I think with that, we're happy to take any additional questions and look forward to feedback, whether it's today or offline.
Thank you. So that was great. But, does anyone have any? No, thank you. Yes, sir. Yes.
Just one
Manager
quick
Dodd.
question. I've heard you talk about the interconnectivity with Epic, with St. David's and Ascension.
Yes.
What about Baylor, Scott and White?
I don't know the extent that Baylor, Scott and White patient information is flowing through the health information exchanges to Epic. You probably know more about that than I do, though.
So great question. Ascension is going to be a little different because Ascension is not on Epic, but ARC is. St. David's also is going to be somewhat different. Baylor Scott and White does feed into Epic, and I think one of the challenges that we didn't think we had when CUC transitioned to Epic, one of the incredibly large work needs was to reconcile the hundreds or thousands of documents that now started coming in. And so when you suddenly open those floodgates, everything came in, which was almost as bad as having nothing, because there was no time to reconcile, everything all at one time. So now they're caught up and they get information in real time. But Baylor Scott and White does feed in. There are different instances, and so it's somewhat different. But if there is a patient discharge, that goes directly into the Epic inbox.
Yes, please. Yes, Manager Dodd.
And this is to our MAP patients, expanding.
Got it. Thank you. Expanding or taking into consideration expanding services to additional MAP and be able to enroll additional MAP patients in light of the at least 175,000 uninsured and those that are not in our MAP population. I have historically and will continue to want to know, when are we going to be able to significantly expand our MAP population and get them included in this services, and whether those needs, those dollar needs to be able to accommodate those the services, when is that going to also, is there going to be a pot of money that's going to be set aside to be able to do that?
I think expansion of the programs is probably its own conversation, but I would say when we talk about dedicated capacity, that is with Central Health's target population in mind, which starts with MAP, also extends to MAP
Right.
Basic. We are anticipating and working
Sure.
now on Medicaid and Medicare enrollment.
Right.
But we will want to be very thoughtful about how capacity is made available beyond MAP and MAP Basic, because there's plenty of need in the community, not just in the MAP and MAP Basic population, and we don't want our patients to get crowded out as we build capacity. So we'll be very, very thoughtful about that. Come back and talk with the board more as this gets stood up about how we prioritize payer mix and what portion of our capacity we would like to extend to Medicare or Medicaid or dual eligible patients.
Will that be a
We want to
conversation?
make sure we're meeting the needs of our patients first.
Is that going to be a conversation we have before the budget?
That's not really a conversation that's necessary even for FY23. These services wouldn't come online until the end of FY23 or early 24. And we're going through the enrollment process now, but we won't be seeing patients until closer to the end of FY23.
And I'm not necessarily tying them to what we will be offering
Yes, ma'am.
based under this plan. I'm talking about how we're going to be expanding.
Expanding the MAP
Yes,
program.
period.
Yes, ma'am.
And
I
being able
don't know
to,
that that's a
provide services to them.
conversation that's currently teed up, but
well, I'd like for that to be one.
understood.
If I need to ask Dr. Brinson and Dr.
Yes.
Bell.
That's fine, yes.
Can I just comment just quickly on, I agree with you 100%. I think it needs to be a bigger question in terms of, we talk about our patients. Where our patients technically are those within the Travis County who meets our eligibility. But if you're paying for services, which all taxpayers are, we need to look at what responsibilities do we have for those patients that go beyond ours that we might be able to support as well. So I agree that it's a much bigger question now.
That's right.
But we need to have a structure from a strategic planning point of view to begin to look at those types of questions. And that's something I'd like to ask that this committee or the chair of the board is here, could talk about how could we form a committee to look at something like that. So I just put that out for conversation.
Excellent. That's great. And we will get back to you all on that.
Okay.
Thank you all for your time this afternoon. Appreciate the discussion and the feedback.
Thank you.
Thank you.
Thank you. It was wonderful. Thank you so much. It was really great. Okay. So again, no motion is necessary here. So down to number 4, confirm the next strategic planning committee meeting date, time, and location. And managers, our next Central Health Strategic Planning Committee meeting is tentatively scheduled on Wednesday, July the 27th, 2022 at 4 p.m. at the Central Health Administrative Offices, 1111 East Cesar Chavez Street, Austin, Texas, 78702. And at this time, I am ready to accept a motion for adjournment. Manager.
Move to adjourn. Oh,
Manager Bell.
after Ron.
Yes.
That's okay.
In terms of the scheduling, it just seems like, can we be more consistent? Because our scheduling, when our meetings are, for instance, I have commitments, for instance, I'm part of the committee.
Microphone?
Oh, sure. Thank you. So I was asking in terms of consistency of the meetings and knowing ahead of time, because they've been changing.
Yes, they have. So what you're asking is that we choose the same day of the week and the same
For
time
consistency,
for consistency.
or before scheduling a meeting ahead
Yes.
of time, if it can be consulted. I think in the past we had a doodle, however that is, and I see Chair has.
If you don't mind.
I might be able to answer that, Manager Musaitev. For today, we have our chair, Dr. Brinson, who had to leave, had a hard stop, and we were having trouble confirming a quorum. So in order to ensure that quorum, we decided to move up the meeting just to make sure we covered everything on time. And then for July 27th, because we're taking that break, a summer break between June 15th and July 27th, but we still need to make sure that we cover the deep dive on the budget priorities. It's kind of a timing issue. We needed to have a strategic planning committee sometime in July. And so we decided to just kind of tack it onto the board meeting, to stack it with the board meeting. I mean, we could have one earlier, if needed in July, but again, we were also trying to just give managers a break. I don't know if that answers your question, but we absolutely will try to be consistent, but we also have to try to work with managers' schedules.
Understood. I have no issues. I just want to know for the long run in terms of consistency. That's all I'm asking for.
Madam Chair.
Yes, sir.
Manager Musaitev, I hear what you're saying. I think based on what Perla has said, in summary of that is we try to have it on the same day and the same time. That's why we actually approve it and send it out at the very beginning of the year. But as you know, things change and people's schedules change, okay? And so as we have to accommodate those schedules and accommodate different people, we may move a meeting, we may move up the time, We may change it so that we try to give everybody as much notice as we possibly can. But the only reason it changes is to accommodate the people on the committee. That's usually the only reason it changes. Okay? You're welcome.
Thank you, Dr. Bell. All right, managers. So at this time, I'm ready to accept a motion for adjournment. Manager Valdez, thank you. And Manager Musaitu seconds. And so the time is 1:18 and thank you so much. And we will see you next meeting.
Thank you.
Thank you.
Oh, I forgot.
Bye.